Hey y'all, happy Baby Friday. Welcome to our first healthcare happenings of the new year. Today I am honored to be joined by my friend and colleague, Annette Bush. Hey Annette, how's your year going?
It's been great so far. Just getting over the cold spell. I'm ready for some warm already. It's the holidays are over, so I'm ready for spring. Where I'm
I
at
know
anyway.
we were just talking about that. Once Christmas and New Year is done, it's kind of like, okay, you're done. But yes. And I see we've got a lot of our regular people pulling in already. So I see Lady is on with us. So good morning, Lady. Hope you're doing good. And Haley in here saying Happy New Year to everybody. So hey, Haley. Oh, and Jeanette. Hey, Jeanette. How you doing? Hope you're doing well. And I think this is Sonal, but again, sometimes when people come on, it comes on as LinkedIn listener or LinkedIn user, so I'm never quite sure. But yeah, today we are going to talk about FQHCs, which are federally qualified health centers. I always have to stop when I'm doing it to remember what the little things stand for as we go out. But Annette is been working in that arena for a long time. And so I asked her, she was the person that everybody was like, oh, because it was something I thought was interesting and would be interesting for people. And so everybody I talked to, they were all like, oh, Annette, you have to ask Annette, you have to get Annette. So Annette was nice enough to come on and talk with us. She is the owner of Bush Consulting Services. So she's an independent co-living consultant that she does coding audits, retrospective coding audits, and E&M training for providers. And as I was saying, she's working primarily with FQHCs. She's been in the field for over 13 years. With the FQHCs, E&M. Also, she did some behavioral health and family practice, so she smattered some other stuff in there. And I think with FQHCs, as we'll talk about, having especially family practice is very important. She has an associate's degree, and she also has her CPC. She's a certified professional coder, and she has, and I wanted to ask you about this one, Annette. She has a CH-CBS, which is for Community Health Center Coding and Billing Specialist certification. So yeah, tell me about that. I hadn't heard of that before.
So there is actually a business out there that I had been following since I stepped into the FQHC world that I didn't know. Of course, this whole world existed. And it's hard to find training. It's hard to find training on billing because the billing is just so diverse and different, and you can sit through a CMS webinar and they can talk about the billing, but then you have to think, well, I live in FQHC world, so that doesn't apply to me and that doesn't apply to me. So I found a business out there that actually offered a certification. I had to go through a class and sit through another 4 hours of testing and to get that certification, but it was well worth it because they do specifically hone in on rural health and FQHC. So there is a little bit of a difference between rural health and FQHC. Rural health is more on the facility side. They tend to be more like, like your rural hospitals and that sort of thing, where FQHCs, which I hear a lot of people nowadays, shorten it down and just say FQs. They
We're
are
getting
more
so
out.
lazy, we can't even use all the acronyms.
Well, it's like, whatever. Yeah, it's an FQ. So
You mean
I,
whatever, right?
I'm struggling with FQ, and I don't know why. That just doesn't sound right to me. I'm still, FQHC, but I still get a lot of people ask me, what in the world is that? So it's just, it has its own area, and not everybody knows about it. And billing and coding, we might get into this a little bit later, but the coding wise is pretty much the same. We still work with our E&M codes and level our office visits and things like that. It's just that we don't get paid for everything, and we have to have certain specialty codes that we have to send in, being at FQHC. So But yeah, I got my
Good.
certification through that business. It's Arch Pro Coding. They offer different, I'm giving them a little plug there. They offer a little bit of a variety of training for different things. But the billing was what I was interested in. And, and actually taking the class, I thought, I took it a few years ago now, and I thought, I really don't know as much as I thought I did. So there's so much to know. It can get overwhelming. So just kind of.
All right. So anybody interested in FQHC certification, you might want to check out. It's Arch Pro, you said, Annette?
Yes, Arch Coding.
Okay.
Mm-hmm.
Cool.
Yeah. They're really nice people.
Good. Now, as I said from, talking about your bio, you've been in for over 13 years. So how did you how did you get interested in our industry? And then second, how did that move? Because you did some other things. How did you move into FQHCs?
Well, to be quite honest, I felt like I probably had the midlife crisis thing happening. And I have spent all my life since I graduated high school. I graduated high school midterm, and I graduated on a Friday, started work on a Monday, but I got into real estate. So I worked for a real estate company forever. I don't even want to say how many years, because this is probably the first year that I haven't done any real estate in all of the years I've been doing it. But I just kind of felt like I couldn't go any further. I was just like, I always wanted to do something different. And it was either this, or you're going to probably laugh at me. It was either this or become an accountant. Because I had a friend who did taxes for people. And I was like, do I want to be an accountant? But then I was like, I'm so glad I didn't go that route, because I really don't like numbers. I'm not really, that's weird to say, but I'm not really a numbers person. So I'm kind of glad I went this route. I went to school. I got my associate's degree in billing and coding, passed my CPC before I graduated. So that way I already had that under my belt before I got out into the world. But I actually externed for the local clinic here in town where I live, and not even realizing that they were actually a federal qualified health center. Once I got into the billing department and all these new different codes they were talking about, and our billing payments and different things that was happening that we never talked about in class, I would go back to school, because I was still in school, obviously, and say, they would ask, how's that extra? And I'm like, I want to know why we didn't talk about T1015, and why do we not talk about federal qualified health centers, and why didn't we, so they just would kind of laugh, because there's, as we all know, when we're in billing and coding, there is just so much information. You can talk.
Yeah.
There's so many different specialties, so many different lanes you can travel down. So yeah, I spent my extern there and ended up, they asked me if I would stay and work for them. And that's kind of just where I have lived in my career of FQHC. So, and billing, coding and billing. Worked in the billing department for 10 years. And after a couple of years I was there and kind of got my feet on the ground, they came to me and asked me if I would do the internal coding audits and work with all of the providers, because at federal qualified health centers, your providers do all of their coding, which was something that was new to me, because I can remember being in billing and working on claims, and I'm thinking, asking the billing manager, I'm like, who does all the coding? Who looks through all these and approves all the coding? And they're like, oh, the providers do, and just, keep your head down and keep working. I'm like, okay, well, they need a little bit of education here. So, and yeah, I don't blame the providers, because, they're there to treat people. They're not there to code. I always say, don't take anything I have to say personal, because, it's just you and me, and we're all learning in this world. And I know you didn't go to med school to learn how to do coding. So they give them like 5 minutes of coding, and then they come out of school, and then we throw them in like, oh, by the way, you not only do you need to treat the patients and complete your notes and order the labs and prescriptions and different things like that, we also want you to code your visit. So, and they just work in the electronic health record. They just, whatever pops up first, they run with it. And so they asked me if I would work with them one-on-one and do the internal coding audits, coding reviews, and review with the providers. And so that's kind of where my heart went. And I love all the providers I work with, and I've worked with many of them for years. And I broke out on my own, and I just have had a couple of them say, they really wanted you to do their reviews. So I'm still doing them, it made me feel really good, because they really, even if they hear something from someone else, they always say, well, we want to run it by you first anyway, because somebody else said this, but we didn't know, but we want you to tell us. So it does make me feel good
It's
that they
nice.
trust me enough to know I'm telling them, proper information, I guess. But yeah, that's kind of the road I took, and I have a heart for it now. And it's just kind of, I always said if I got released out into the real world of billing, I probably would not do so well, but I don't know. So that's kind of how I got into it.
Well, so is it the working with the providers or the billing? Which part do you like the most out of, what you're doing with the FQHC?
So I really like working with the providers, because I like to see improvement in their error rate. I'm like, okay, something, no matter, you can say the same thing over and over again, but it's like, okay, I've got to say it different. I've got to do something a little bit different the next time we meet, because, their patterns are still the same. So let's try different. So that's always a challenge for me. To try to keep it, interesting for them, because I don't want to bore them to death. First off, I want to make sure I keep their attention. So, just things like that. I love, they educate me as well. And I'm always asking them questions about diseases and disease processes. And they're saying, well, the reason I put this in there is because of this. I'm like, oh, that makes more sense to me now. So they do educate me, which I love. But the billing part was also challenging too, because working AR, working denials, and trying to figure out why a claim didn't pay when it was supposed to, or why we didn't get paid our specific payment rate when we were supposed to, or, just different things. Each kind of position had its own challenges, but I still just prefer working with the providers, because like I said, they've all been super nice. I've even had people say, watch out when you go meet with Dr. So-and-so, but I was like, they never act like that with me. They always just act normal with me. So I don't really see it. And I just, but yeah, I love working with the providers. They're very nice. I feel like sometimes they get a bad rap.
Yes, I do. I know. So I've heard that a lot too about certain physicians. And when you go to meet with them, they're like, "Oh, well, this one's argumentative, or this one is always, always so loud and yelling." And I think the exchange with them. From my background, I was taught, from coming up, it's like in your approach too. Going in there, even if somebody didn't do well at all, I always find some positives to start with, and if you come at them that, and I would give my little, I'm here to help, we want to make sure that we're protecting you. And, so when you lay it out that way, I find then you can really have a good exchange back and forth, or, asking them leading questions to show you're not just there to lecture. I'd say, okay, I have one physician who was just all over the place with her coding. She was a new one. I mean, things that should have been 4s were 2s. She put things that should have been 2s. She was putting 4s and 5s. And I'm just like, I just don't get this. And so I asked her when we met, I said, I just want to understand what you think. And, like, what were you taught on how you choose your level of service? Like, what is your thought process behind it so I can help you better? And she says, I tell you, when I first got here, they put me with a seasoned physician, and he was supposed to train me on E&M. And his training to me was, don't always use a 3. That was it. And
I had a provider
like, so that I'm looking at this.
I know, it's so funny, the stories that you hear, because they're just all over the place. Sometimes I go in there and I'm like, you know what, I am just, really as confused as you are. So let's sit down and look at it together. And a lot of times it's the electronic health record. So I had a provider one time, and literally it was like, gosh, I don't remember now. It was like something like somebody was like catching a football or something, and they bruised their finger, basically a bruise. It wasn't even jammed. By the time they got there, it wasn't even swelling anymore. It wasn't broken or anything. It was like, and I said, so what made you think to code this as a level 4? Because they gave it a level 4, and they said, well, they did it through, they used the electronic health record, the E&M coder, and it populated a level 4. And they were like, oh my gosh, I never had a level 4 before. So they kept it. And I'm like, oh, okay, well, that's, so, I mean, you hear all kinds of things. I'm always against the E&M
Yes.
coder. I'm very familiar.
I agree with you totally.
And I know the eClinical Works that I use regularly does not have even the 2021 updates in there yet. So it's like, please, I had a provider ask me
yes.
this last month, do you recommend? I'm like, no, please don't even look at it. Just ignore it. Don't even think it's there. Yep. So yeah.
Yes. I totally agree on that one.
Yeah.
Yeah. They become too dependent on that kind of stuff. Now with your consulting company, so does your consulting company only work with FQHCs?
Yes.
Or do you do other stuff too?
I could, but like I said, my heart's with the FQHCs, and that's kind of where I gravitated to, just because I know there's a need. Because, FQHCs, if anybody that has worked for one, or anybody that does work for one now, just, everybody that works for FQHCs, they wear so many different hats. You might have a back office nurse that might have to go cover the lunch hour at the front desk because, everybody called in sick today and everybody's rotating shifts around. You might have a biller rooming patients one day, maybe just because, you're short staffed. So it's just always a hustle bustle, and there's always just, things, everybody's needed everywhere at every given time, any given time of the day. And I just feel like, if I could just give that little bitty part to help them understand the coding part of it and what they need to get documented to support their codes, that way they can whiz through that part of it and then focus more on healing the patients and taking care of the patients, and not worry about, I have had talked to providers, they literally get nauseated over trying to figure out how to code. And I'm like, it's, just let me try to help you, just let me just kind of give you examples. Whatever I need to do, like everybody's different. Like you say, everybody's personality is different. Their mind's different. And you kind of got to figure out, okay, one person you can literally just sit there and say, do this, this, and this, and they get it. But other ones, they just can't, no matter how many times you tell them. So I typically just work with FQHC just because the providers do all the coding. And I know from personal experience that is a need. There is a need there. So that's kind of where I'm leaning towards.
Great. Well, I just wanted to, while we get into our topics discussion today, to put up some comments from some people. Melvin said, it's always a pleasure to hear from Annette because you're very knowledgeable on FQHC. So I want to make sure I put that up. And also our friend Lady saying that you are the guru for FQHCs. So, and there was another here, Jeanette, she said that she worked for FQHCs for 19 years, and she loves serving the underserved and uninsured population, which is moving into the FQHC issue. That's really what, an FQHC is. So that was going to be my first thing to kind of, get into discussion of, FQHCs have been around since 1991. So what makes a facility an FQHC?
So there's a lot of, there is so much information that we can cover here. Basically, FQHCs, they're outpatient clinics. They're here to basically target the disparities of and focus on improving the health status of those underserved communities. Maybe maybe there's barriers in economics or their geographic locations. Maybe they don't have the transportation to get to the doctor that's 45 minutes away. But everybody needs to have access to affordable health care. So FQHCs focus on those areas where there is barriers and there's limited access, which I think is great. So that's kind of where they focus on. And there can be shortage areas in wealthier neighborhoods, which we just don't know. There could be pockets of population in those wealthier neighborhoods, though they can be anywhere. But they also accept, they will treat anybody, regardless of their ability to pay their bill. So that's one of the things that an FQHC has to offer, a sliding fee scale. So depending on your, the poverty level, depending on where you fall in based on the number of people in your household and your income in the household, where you fall in on that scale, and each one is different because they get to set their own scale. They can come in and see the doctor and only pay $20 today, so that's one big thing, is we don't discriminate, or we don't limit, just because you can't pay. They might be homeless and have no work, or things like that. So that's kind of what FQHC's focuses on, is where there's a need to try to improve those health outcomes. Of course, that's what everybody's kind of shooting for, right? So
Yeah.
that's much what the FQHC world does.
So I'm sure there's hoops that facilities need to jump through to qualify to be an FQHC, that goes into some kind of federal regulation, right?
Absolutely. So the HHS has those regulations, and then you've got HRSA, your Health Resources and Services Administration, who regulate those policies. So what happens is, once you can qualify and become and get labeled an FQHC, yes, you have all these regulations that you have to keep in place, and the government really enforces that. They will come out and do site visits. They check and make sure you're doing your billing accurately. They make sure you offer the sliding fee scale. They make sure you have different policies in place for, quality measures, safety. They make sure the waiting area is safe. They will actually they might actually sit in your waiting room and just kind of observe the front office all afternoon, just to see how you treat your patients and see how things are going. They can interview anyone in the company. So yeah, there's a lot of regulations that have to be followed, and HRSA comes out and does those site visits, and just to make sure that happens. So yeah, I've never personally been involved with a site visit, but of course my managers have, and they've been gone maybe all afternoon or all day with visiting with them, because they come in with their binders and they have checklists that they go through, and again, they have the questions, and then they also educate on things that need improvement. One of the things that there is a checklist. There are so many things that you need to have in place as an FQHC. But one of the things that I really thought was really cool was we operate under a board of directors, and 51%, the majority of our board is patients that we serve in the community. So, I thought that was really great. You can have a board that, maybe you've got, and all the policies that you want to change or amend has to go through the board. I can remember being in billing, we would come up with things regarding, collection agencies, or if we wanted to change prices of anything, everything had to get approved through the board. But you could have a board member, maybe sitting at the table with maybe some president of Walmart or a bank or something, but that maybe the next person sitting beside them, maybe they were homeless last year. You never know. You just never know who you're with. But the board has to be 51% patient based, which is great, which I think that's, I don't know, just to know that that our patients have a say in how we run our business, because we're getting that feedback from the community, because we're here to, work with the community. So I just thought that was great. But yeah,
I thought that was pretty neat, because I was reading some of the.
Yeah.
Sorry.
No, you're fine.
Yeah,
I
was reading some. Go ahead.
HRSA website has all of the, how to become an FQHC, how to stay compliant with all the policies. They have a lot of great information as far as they show the shortage areas in the whole country. There's different maps and things on there that you can look at. So yeah, there's all kinds of information on there. But yeah, it is a lot of information that we have to stay up on, and making sure we keep all of our policies and they make sure that we're following all of our policies and procedures. So it's a lot. We always said that, people don't even realize, sometimes our patients don't even realize when they come to see us that we are an FQHC. And a lot of people don't even realize, how we're more regulated than, Dr. Smith, who owns a private practice, on his own, because we do follow those government protocols and things like that. So yeah, there's a lot of regulations that we have to keep in place. So
it's a lot of stuff to keep on top of.
Yeah.
With the payment, because is it, and this is where, I don't know a ton about FQHC. So I know when you're billing for an FQHC, y'all use both the 1500 and a UB, or how, from that billing standpoint, how do you get those claims out?
So this is where it gets confusing. So, depending on the payer, let's just start with Medicare, because Medicare, we have to make sure the patient has Part B coverage because we're outpatient facility, but we file our claims to Part A. And we file those claims on a UB, and we have to make sure that we code all the services that we performed, but we also have to make sure that those services that we performed, that we bill to Medicare, is on the qualifying list, because being an FQHC, we're limited on the services that we are able to bill for. We have to have a qualifier code. So if Medicare created some G codes for us to use on our claims, whether you're a new patient, established patient, whether it's a behavioral health claim, if it's an annual wellness visit, an IPPE, there's certain G codes that have to go on there with those other actual codes for those services, before we can get paid. We actually code for everything that we do just for reporting purposes, and they will pay us on our G code for our PPS rate. And then we also have to report a report that has, and usually the CFO did this at one of the facilities that I work for, that shows, like, so say for instance, like your flu shot, we're not going to get reimbursed for a flu shot. So we will report it on our claim. And then when we do our cost reports at the end of the year, then that all of those flu shots are going to get in there. And then at the end of the year, they'll send us a lump sum payment to cover the cost of administrating those. So, but yeah, so that's Medicare. Medicaid, same thing. We are limited to certain codes. That's covered. We do have to bill with a T code, the T1015, which I brought up earlier. If we don't have those T codes on there, they don't pay us our RAP payment. They don't pay it. We call it a RAP payment. They don't pay us at that PPS rate. Or they might deny it. They may just hold it. I think each state's different depending on where you live. So, but yeah, we need that T code on there. Commercial insurance, we do bill commercial insurance. Of course, we just bill our services out, and they pay us however we're contracted. As long as we're contracted with that insurance company, we will bill any insurance, as long as, and they'll process it however they process it. If we're not contracted, if we're out of network, they'll process it that way. One of the things I also brought up earlier was the sliding fee scale. We are supposed to offer that to everybody. So even like if someone has the marketplace insurance, and say they have like a family deductible of $15,000. So maybe they qualify on that sliding fee scale. Once your insurance processes, maybe they qualify for some kind of a discount with that sliding fee scale to get their deductible balance discounted, maybe at 50% or something like that. So, it's something you have to offer that to everyone. So yeah, we file claims to everybody.
And now, we were also talking earlier, when the FQHC gets payment, they're paid in like lump sum. So a patient may present to the FQHC and have multiple services done. You report them all, but you get that, what you were calling the wrap payment. So they get like the one payment for all things that are done. When it gets billed on the claim form, and this is just my curiosity, are your regular individual fees for each thing listed, or is everything listed as a zero because of the wrap payment issue?
We have a fee for everything listed, and this is the for the clinics that I worked for, and everyone may be different on how they do it. The billing, they may do theirs differently, because I know each state Medicaid and each clinic could do differently. But I know for us, we left all the fees on there, and then once we got that payment, we posted it to the payment code, like that G code or that T code, and then the rest just got adjusted off when we posted those payments.
So I guess maybe it depends on how you want your AR to kind of look.
Yeah.
Okay.
Probably. I know sometimes we put one of the things on that T code, because even like the managed care Medicaids, once we send that claim out to them and they paid, let's say we billed out $100 and our T code, maybe we get $200 payment for that. So maybe we billed out $100, that managed care paid us $50. Well, then Medicaid would pick up the $150 to match that PPS payment. So we would post that and then put it in a status and then wait for the wrap payment to come in for Medicaid, and then it would all be done. That was the only way we could track it that way. So.
Okay.
Yeah.
Okay. And yeah, usually y'all, as y'all are listening to Annette espouse wonderfully on FQHCs, just throw your questions in there as you have them. I put up in the links there, the HRSA website and some CMS website links. These are things that Annette shared with me to, give to y'all so you could go in and put some stuff up. And Annette, we do have a question from Molly that she's just asking, and that's okay that you're late, Molly. We're glad you joined us. Are the FQHCs funded by the government?
Yes. So they get their money from state and federal government payments, of course, through the Medicare, Medicaid. And there's also grant funding that they could also apply for. I'm not a grant writer, so I'm not going to pretend I know all about it, but there are certain grants out there that we could, apply for, that we could write and apply for. So maybe we want to hire, let's just say we needed to hire a coder to come inside and do our internal coding audits. So we could apply for funding, and that's where that salary would go. But we would also have to make sure that that's where that money went to. Maybe we're going to expand our clinic. Maybe we're going to add on. We have to make sure that we're providing the information for the need for that additional funding. So there's a lot of different things. There's a lot of different laws and things like that required for that grant money to request the grant money. We also get incentives. So, doing those, especially like for the Medicare preventative services, there's quality measures. They want to make sure that we're meeting all those quality, make sure we're hitting on those well child checks, doing those different screenings, the lead screenings, or, different things like that. So you do get incentive too, based off of any of those quality measures that you hit on. So all those codes mean something to our insurance companies. I mean, we all talk about it. Those codes tell a lot. They tell the story about everything, but they also tell, those preventative services, of course, that we're doing, and that we're staying on top of it because we want to keep our patients healthy and out of the ER. Yeah. So they offer us incentives for different screenings and things like that. So, that's another way.
So then the FQHCs, y'all also report MIPS, or is it? So do you report the MIPS codes then when you're doing the reporting?
Well, so they might tell us, if you report this G code and do this service, I have recently I had a provider that I forget the code. It was a G code for the diabetic foot exam. And that was one of the quality measures. And I think he was just excited that he actually remembered to use a code for that. But he didn't document anything. Like, you have to document certain elements. And I'm like, so that's an education part there. So yeah, I mean, they let them know, certain codes that they need to use of what they're going to get. So I know, like, on the quality side, they will tell them what to report and what code to use. So they do help them out with that. So.
Okay. And then we have Jessica was asking when you were, and I'm assuming this is because it came up when we were talking about this RAP payment. So is that an episode of care type payment?
Yeah. So our visits are, all the visits that we have are face-to-face. They must be a face-to-face encounter with the patient with a qualified physician that's listed for the FQHC. So there are certain visits, like for Medicare, for instance, we can't do a nurse visit because a nurse visit's not a qualified provider. There are certain ways, I know, depending on your clinic, you could, I've read in the manuals, you can, put that on the next office visit, and it's like a reporting thing that way. You can report it that way. But so yeah, every visit type is a face-to-face. So that's kind of another thing that I just thought of, like 2 visits in one day. So we're entitled to 1 RAP payment a day. But there are some exceptions. Medicaid, so typically they will pay if you see a provider, a medical provider, and a behavioral health provider on the same day. You just have to know how to bill it. It gets a little tricky. You have to make sure you have 2 different diagnosis codes, and you have to make sure they're matched up properly on your claim form. You make sure you got your modifier on there. But I don't believe you're going to get your full RAP payment from Medicaid. Now, Medicare is different. Medicare will pay. Like, if you have you send a claim into Medicare for a medical visit and a visit for a behavioral health visit all on the same day. This is the state that I live in. You have to make sure the diagnosis pointers match up, get that modifier on there and all that. So I do know there are some states that offer, like, maybe they see the medical provider today. They see the eye doctor. Maybe your clinic has an eye optometrist. Maybe they have a dentist and then behavioral health. Maybe you have all 4 services, and you can come and do it all in one day. And your state may allow you to bill for all those different services on one day, but I'm not sure how they pay those. They allow those codes to go in, and they acknowledge them, but I don't know if they would pay a RAP payment on all of those. Maybe you get 1 RAP payment and you're done. Yeah. So yeah, it just depends on the states, because all the states are different depending on, yeah.
So when I was doing a little research for our conversation, I was reading that, and then, in us talking, that the RAP payment, and when you go to the FQHC, it is for that day, to start out. But there are exceptions where you could use, like, modifier 25. If a patient comes, let's say, to the FQHC in the morning because they're hypertensive, it's their follow-up thing. So they see the physician, they get their checkup, everything's all good. They go on their way, and then, they're doing some yard work and, step on the rake and it whacks them in the head. So they have to come back now because they've got, an open wound on their head that needs suturing or needs attention. So in a case like that, because of the 2 totally different kind of things, you would be allowed to then report that additional service that was done and use modifier 25, just like if it was in any other kind of clinic that was being seen. Are there other modifiers? First of all, am I correct in that? And then secondly, are there other modifiers that y'all use that are applicable?
Well, you're correct on that, because, you're going to have your different diagnosis codes of why they were seen. So that's going to be 2 separate encounters. Sometimes Medicare wants us to use 5.9 instead of 2.5. So we just kind of go with what they tell us, because, the rules are the rules of what we see, well, I say that in our CPT books, they tell us, but then you have certain payers that might say, well, no, we don't acknowledge that 2.5. We would rather have a 5.9. And it's like, but it's not really technically, that's not described that way. So I wouldn't use a 5.9 there, but if that's what you want, okay, we'll give you the 5.9. And if that's how you acknowledge it, and it could just be the way their systems are set up, because, all these claims go through electronically. And if there's anything, that they may have set up wrong on their end, it could spit a claim out. I have had claims sent to Medicare and deny, telling me that they've already paid a claim for that day. And so I'm like researching, I'm like, okay, the patient's only been to our facility once that day. So it's bouncing up against another claim. So did they leave here and then go to the ER? I'm like trying to figure it out. That's pretty much where you have to kind of pick up the phone, make a phone call to Medicare and say, I don't know, what happened here. Or maybe their claim went in before ours did or something. But yeah, usually they will pay either with a 2.5 or a 5.9. We have to put the QW for the CLIA waived, different, those things like that. There are some, we do cover for our PEDS, the vaccines for children. If we get that from the state, so we would put an SL modifier for those, and then they'll pay us for the admin. So yeah, there's some things like that. It's just knowing, and that's pretty much the most part of it. There's nothing really too crazy with the modifiers. And a lot of times I find that to be real honest with you, a lot of times those claims won't deny because we forgot to put a modifier on there. It just depends, it might make it through because they're only looking at that T code, or they're only looking at that, that one code that as long as that code's on there. So, but yeah, if I know with Medicare, because we have, we are credentialed and set up and contracted with them as an FQHC. If we don't have that certain G payment code on there, that claim just sits there. And, when you're working your AR and then you go to look and it's like, oh, we didn't put the G code, the payment code on there. So they won't pay it without that payment code. We have learned that. You have to learn that the hard way, I guess. But yeah.
Okay. So if you are not listing everything or the modifier issue, you might be okay. But yeah, the G code that's the driver. Do you usually use that as the first listed code then on every claim?
Yeah, absolutely. It goes on first. We have to make sure it's at the top. So before we send our claims out, make sure that's that first listed code.
All right. And just again, as we're having people come in, and Pam made she said it's very fascinating. It's definitely a different world than what I live in daily. And yeah, me too, Pam. That's why I wanted, to have somebody come on, because I think some of these things are just, these other areas are fascinating that I want to, kind of get a little more info on. So your information is getting very appreciated here. Annette, here's another one. Jessica said she's really enjoying hearing things that I've studied be discussed by someone in this niche, Annette. So thank you.
You're
so it's good. And again, if y'all have some more questions, I'll look in the comments here if anybody had a different question in there. But if you've got questions, throw them on in here. There's Sonal Patel. Hey, Sonal said that you've explained to her many times on the complexities of FQHCs. So for people that are listening, if we don't have, while I'm searching for other questions, or if people are going to make other comments, if someone is just as fascinated, with listening to what you're saying about the FQHCs, what kind of person do you think is like one best suited to kind of hit the FQHC? Because some people you have to have the G code, and we don't get paid for this, but this is a bundle. It would like drive them bananas. And other people, they kind of, like to dig into that kind of stuff. So like, what do you think like a best suited personality kind of would be for this? And then for somebody that is digging our conversation, what would they need to do to learn more about FQHCs?
So if you want to learn and work in FQHC world, especially in the billing world, just know that you are always going to have a 3-ring binder full of notes sectioned off because you can't treat everything the same. I had at least 3 notebooks that I would have to recopy just because I would run out of space. Because once you get used to billing and coding visits this way, something changes in our world. And it's like, well, now they want us to do this. So we have to go whenever the rules change, we have to, make our changes in our notebooks. It was always difficult training and onboarding new billers because it was like, there's just so much to cover because you have to look at the claim. And first off, is this a self-pay claim? Is it going to commercial insurance? Is it going to Medicaid or Medicare? You look at your insurance, you got to make sure that they're eligible. You have to line by line, make sure we have all the proper codes on. So when you have to have a notebook full of, okay, this is Medicaid, this is my checklist. Okay, this is Medicare, here's my checklist. Did the sliding fee scale adjust properly because they got a 50% discount? So we have to make sure we're not billing them full price. So there's a lot of things that you have to look. So if you are one of those people that are okay with having to know 1,000,001 different things in your binder and know where to go and find it, perfect. And then you'd probably be surprised trying to get into an FQHC in your area. I would just look around and see, I don't really know how you would find out because I didn't even know the one I worked for. I had friends say, well, where are you working out now? And I would tell them like, oh, you're working at the free clinic. And I'm like, no, it's not a free clinic. We bill people and they pay. And I'm like, but they don't understand the concept. But I think you would be surprised, which hospitals or which, facilities, healthcare clinics in your area are actually federal qualified health centers. So maybe just doing a Google search, looking online, you can look up FQHCs and in your area, in your state, and it should give you a list of the FQHCs. I was kind of surprised at some of the hospitals that are around me that are actually labeled as rural hospitals. So yeah, I mean, if you're the type of person that's not strictly by the book, well, the book says this, and it's this every single time, this is not for you. So if you're, you have to know so many different things and keep up on it. And that's why I kind of struggle when I sit through coding classes and webinars, because again, I'm thinking, okay, well, that doesn't pertain to me. I always have to make sure I block out certain things. And, it's just hard to keep it all straight, but you still have to know it all. You still have to kind of know it all because, you're certified. You got to keep up with your certification. So you still have to be on top of everything anyway. So,
yeah. Well, I just Googled, I looked up while we were going through, there are over 1,400 FQHCs in the United States. So there's quite a few places out there that need help. And Jessica, who had made that comment I showed you before about she said she's so excited about this, she can barely stop taking notes. So, I think you've got to maybe have a convert there.
If you would see my office, my husband just looks at me and rolls his eyes at me because I'm like, look, honey, I cleaned off like 12 inches here because I have literally notebooks everywhere. And I'm kind of one of those nerds. I love to buy, the big notebooks and the little notebooks and just kind of label them like this one's for, E&M and this one's for billing and this one's for Medicare. This is for Medicare. I just have lots of notes. I do it myself. When I take a webinar, I have a specific notebook for my behavioral health. I have a specific notebook for my Medicare webinars. So yeah, I mean, I'm a big note taker. I'm old school. I love my pens and paper. So yeah.
Yeah, I do too. I've got a stack of different notebooks of different sizes that have different subjects on each one of them. So I'm the same way. Yeah, I'm it's just like with the coding books. I do have an encoder, so I have them electronically. And I'm like, but yeah, there's just something about being able to flip through the book. And, no, I don't like carrying around an extra 15 pounds of stuff with me. But, I just like having that book. So it's the same thing with the notes.
I go straight to my book. I forget that it's like, oh, I could have looked it up online. I have it on my computer, but I always forget. I always pull out my book. So yeah, I'm a
Yeah.
book person and a notebook and a pen and paper person too. So, and you kind of have to be, everything changes, it's, things get different. Like one thing, this year, just to kind of talk a little bit about that, is our community health workers. That was in the final rule. We get to actually incorporate in our community health workers, who have always been a vital part in the Federal Qualified Health Center for those people with social determinants of health. They need help with transportation. They need help with food insecurities. So now we actually get to acknowledge their time and bill for it. So there's just all kinds of new,
wonderful.
all kinds of new things that there's always changing. So.
And when y'all get when they do decide to change things, as they do constantly, as we're in things, are the changes coming through HRSA? Are they coming through CMS? Are they coming through whoever that particular payer may be? Like, how do you get notified for those?
CMS. So when I actually worked in billing and had a billing manager, I really pretty much, worked my day to day, like, created the claims, posted payments, worked the mail, answered the phones, worked AR and all that. And I didn't really pay that much attention to the changes until she came out with her little notebook and said, we need to have a meeting because this is what we're going to start doing. So I didn't really pay that much attention until closer towards the end, when I started to think about maybe branching out on my own. And then I was like, where does all this stuff come from? So it's all out there and you can find it. It's really easier than what I thought. But yeah, I just pay attention to, I get notifications from CMS, but then we also have to make sure that we're paying attention to our state Medicaid, because just because Medicare says something doesn't mean that Medicaid is going to follow the same guidelines as what Medicare does. And the same with your insurance payers. Your insurance payers aren't, and just because we're an FQHC doesn't mean that they're going to follow the same, well, we're an FQHC, that doesn't matter to them. They're going to pay us the way our contractual agreement states. But yeah, just through, I keep up. I get all the Medicaid bulletins from our state that come through, which is a lot. And sometimes it's like, oh, I got to go through 15 bulletins just to see if there's anything in these bulletins that pertain to the FQHC world. So I kind of keep an eye on that. So just keep up on your state Medicaids and CMS. There's a lot of information on CMS website. You can pretty much find, if you dig deep enough, you can pretty much find what you're looking for. Sometimes it's hard and sometimes it takes me a while. It's easy to go down the rabbit holes. I've done it. And not every health clinic bills for some things. We can do the transitional care management, the diabetic nutrition management. There's so many different things that we can do, but maybe your clinic doesn't do it just because they don't have the manpower. How are they going to track it? Who's going to do it? Which nurse are they going to pull to, to take care of all this? So that's, it comes down to the quality department and who's going to be in control of this. So there's things that we can do that maybe your clinic doesn't provide that service for. And that's another thing, just kind of knowing what you do and what you don't do. So, I just kind of know, well, we're not doing that. So just kind of don't think about that for a while, until we decide to do it. And then I will hone my skills and learn about it. So just because it's out there doesn't mean that you have to know everything about it. So that's and I'm the type of person, I want to know it all. I want to know everything about everything, and I have to stay in my lane.
Now, I thought of it while you were speaking of this too. Just again, another. Can FQHCs report telehealth visits, or do they have to be in person?
Yeah, no, prior to the pandemic, they had to be in person, but behavioral health was allowed to do via telehealth. So, and the FQHCs that I work with now, I mean, I'm asking them all the time, and they're pretty much they've kind of done away with telehealth. I think it was just more. I think honestly, it was almost kind of more of a hassle, because you got to remember, a lot of the people we work with are maybe the elderly. I'm just saying, like 65 and older. And like my dad does not, he still has a flip phone. He wouldn't know what to do, how to even begin. I mean, he calls me for everything and anything. So, we just got to remember who we're working with, and, they don't understand that it's a visit, and trying to organize it is more time and effort than it is to just to schedule them and have them come in. So I know the health centers that I work with currently don't offer them as much. I mean, they still do, but I think it's mostly just the telehealth, but even then it's not very often. I honestly don't see it that often. So.
Yeah. Well, also, I was thinking too with an FQHC with the population, you also may have patients that don't have laptops and internet, so there's that issue too, that maybe they don't have it. They'd have to go to a library. Well, if you're going to go to a library where you're sitting there in front of everybody, wouldn't you rather go just to the clinic and be there face to face?
Exactly.
So, yeah.
Yeah. And it's hard to, it's hard. Just, I don't know. Again, we just reached that certain area of the population that just doesn't have everything at their fingertips,
Yeah.
And it's just, it just kind of makes you just stop and think for a minute sometimes, so, but yeah, it just may not always be, maybe to some it's, worth it and they can do it, but I don't see that with every patient. And I don't see the telehealth visit as often since they've kind of wound down saying we're going to end the pandemic, those all kind of started winding down a bit. So.
Yeah. Okay, cool. Well, you have given us a wealth of information on FQHCs, FQHC. See, I'm with those acronyms. I'll just start FQs. I'll start getting hip too.
Yeah, that's fine. That's what I hear often. Thank you.
Yeah, that sounds weird.
It's a lot of information. I mean, there's just, when people ask me, I always kind of have to re-ask, well, I need specific, what more specific do you want me to help you with? Because, a lot of the questions I get are just very, very general, and we could be talking all day over certain things. So yeah, it's a lot of information.
Yes, no, well, I super appreciate your time, and we are at the hour already, so I know, but I know, but well, like I said, like we were talking about, and everybody seemed to be enjoying our conversation. So maybe in the future here this year, we can have you come back on for like a round two and kind of dive into maybe a specific issue for an FQHC a little bit longer. Now that we've talked about kind of like the overview of how everything goes with them. But I super appreciate your time.
Thank you for having me. This was fun.
Yes. So, everybody, we will, I think my next guest is going to be on anesthesia. She's one of my former students that is in Tulsa out in Oklahoma. She's an Okie. And anesthesia is another one of those specialties. I was telling Annette, if there's like one specialty, and this is just fessing on myself, if there's one specialty, I was just like, oh, really? It was anesthesia. And it was because of not the coding, but the formula and the spreadsheets and the pie charts that some people use. I mean, it would just give me a headache. So, I think our next healthcare happenings will be my friend Tanya Bevan, and we will be discussing anesthesia reporting and all the fun stuff with anesthesia. But Annette, I know your schedule is always full with calls, so I appreciate you spending the time with us, and look forward to having you back again.
Yeah, I'd love to.
And so, thank you. Good. All right, and we're getting a lot of everybody saying thank you, and I saw a lot of little hands and hearts and stuff coming up on the screen beside me as you were talking about stuff. So, all right, y'all. Well, everybody have a good rest of today and enjoy your Friday tomorrow. Have a good weekend, and we will see you next time to talk about what's happening in healthcare. Thanks, y'all.
Bye, everybody.